I guess it's afternoon. Yes, good afternoon. We're going to go ahead and get started. Thanks for coming in to join us for strategies and techniques for transitioning negative pressure wound therapy across the continuum. We're very happy to have you join us today. This CE presentation was sponsored by an educational grant from 3M Healthcare. My name is Dot Weir. I'm going to just be the moderator today. I met a lot of you. I do come from Saratoga Hospital Center for Wound Healing and Hyperbaric Medicine in Saratoga Springs, New York. And I'm going to go ahead and introduce our faculty so that we'll just transition between the speakers. I'm joined today by Liz Faust, who we all know, and she's a nurse practitioner who works with Tower Health, specifically at Reading Hospital in West Reading, Pennsylvania. Emily Greenstein, who is a nurse practitioner and co-director of the Limb Preservation Program at Sanford Medical Center in Fargo, North Dakota. Have you gotten rid of your snow yet? Okay. And then last but not least, our good friend Rob Klein, who does a lot in Greenville, South Carolina. He is Associate Professor of Surgery at the University of South Carolina School of Medicine. And he's the director of the wound care program for Prisma Health. And I just recently visited there, and it was a quite impressive program. So these are our disclosures. And this is just letting you know that if we talk about anything off-label or something that is investigational, we will absolutely disclose that. So these are our objectives, and what we're going to do, I know you can read that, but we're going to look at just hospital admissions, the cost of them. You know, we all use negative pressure and some of the challenges and some concepts and ideas for transitioning the patient out of the acute care into the outpatient to the post-acute section. And then talk about peri-wound management locally and looking at some of the newer drapes that are available to help not only get a good seal, but also to protect the peri-wound skin. And then what everybody really likes is that our presenters will also be presenting some cases. So I'm happy now to turn it over to Liz Faust.
Thank you, Dot. Hi, good afternoon. Wasn't that good food? I really like this has very good food. I said in the breakfast session, I'm saying it again, so thank you. So my portion of this discussion is going to focus a lot on kind of the data and the evolution of both the products and the science that are surrounding it. And then I'm going to talk about what negative therapy does, and I'm going to highlight that with one case study and then hand off to my colleagues. So obviously this is a grabber slide. These are all wounds that can be treated with negative pressure. And really my question is, did you know that there's a relationship that exists between early implementation of negative pressure and an overall reduced length of stay? And that's with traditional negative pressure wound therapy. And at the end of this conversation, we're going to talk about installation and dwell. But we're building upon our literature. So this is going to be building blocks, much like a pyramid. So we've come a long way with our options for negative pressure therapy. So we've obviously got open abdomen, which is a staple in our critical care units. Negative pressure that is portable, so we've got mechanically powered and non-mechanically powered, and then we've got installation and dwell, and then incisional. The installation and dwell has come up with multiple dressing kit options as well, but you know, since 1995, we've really come a long way with this therapy. So just to highlight what negative pressure is compared to installation and dwell, you've got the right side is, oh, you know what? This doesn't have a pointer, my bad. On the right side, you have negative pressure phase, which is our macro and micro strain, which is well documented in the literature. And then installation and dwell is a fairly new concept, I guess, in terms, although it's been around since about 2013. You've got the solution that will instill within the foam, and it will dwell within the wound. I call your attention to the left-hand side of that wound picture to those small microtunnels. So those are areas that when we're simply irrigating, thank you, sir. That when we're simply irrigating a wound, we're not going to be able to cleanse those areas. But there's something about dwelling it and soaking it that will help solubilize that debris or that bacteria in an effort to get it out of that wound as well. So just the little nuances that are slightly different. We've obviously had evidence that has built upon this, and we will continue to build upon it. So obviously, there's been bench research, preclinical trials, clinical research, protocols, and product enhancements. Some of my favorite bench studies are one that shows that pulse lavage and negative pressure with instillation and dwell will cleanse the same, but instillation and dwell will reduce the edema in the area, whereas the pulse lavage will actually increase the edema in an area. And because I grew up in a PT-driven clinic, I know that edema is the enemy of wound healing. We've also got porcine studies that show that instillation and dwell will increase your granulation tissue formation about 44% greater than just traditional negative pressure therapy. We have things that show that we increase closed wounds, reduce length of stay, decrease surgical debridement, decrease cost of care. We've got protocol recommendations as well. So the evidence-based pyramid really builds upon this, and I'm not going to spend too much time belaboring this, but you can see that there's a large amount of data, which would include our latest publication by Gabriel in 2021. That is a meta-analysis. And that there's more than 2,000 peer-reviewed publications as of October of 2022 on negative pressure wound therapy. So just some of the historical stuff is things that we talk about with how do we choose our solutions. So this study showed the effectiveness of negative pressure versus instillation. It had PHMB as our topical wound instillate, and it was non-infected wounds. So you can see that the patients that received negative pressure versus instillation and dwell had a reduction in the overall length of stay and OR trips, time to final closure, and then closed at time of DC. Again, reduced OR trips, surgical procedure, and length of stay. Then we compared the PHMB to just saline solution. And what we found was that of those patients who had the saline, they actually had better outcomes than those who had the PHMB. So this shifted our recommendations for the expert panel to move from an antiseptic solution to one of just normal saline solution. And this is just highlighting that.
I'm sorry for my ignorance. With the instill, are we turning off the pressure and instilling, or are we flowing through the...
Yeah, so when we're dwelling the solution, the negative pressure actually goes down to negative 25. So it never fully gets turned off at that. So although it's inherently intermittent, it's not fully off at portions of the time, much like the DPC you would see. It's a great question. We actually compared it to intermittent as well, and we also saw that there was a 44% increase above that, that there was improved wound healing beyond that as well. Okay, thank you. All right, so some of our newer literature, so this is from Dr. Kim in 2020, and it showed the impact of negative pressure wound therapy with instillation on wound requiring operative debridement. And so this is a very content-dense slide, but just to see, it was a patient that was admitted to the hospital for the wound. They required an excisional debridement, and it had to be greater than 4 centimeters on any plane. What we can see with that data is the primary endpoint was going to be the number of debridements. The secondary endpoint was how many wounds were closed or covered, and time to redeem ready for closure. We actually found that there was a 3-log bacterial difference between those who received traditional negative pressure versus the instillation therapy. So there was a reduction in the bacterium. And really the biggest things that we found is that the instillation group is 3 times less likely to be rehospitalized than just traditional negative therapy, and that their wounds were closed at a higher rate. So 3 of the 4 were closed versus 1 of the 4 of the negative pressure. So from that, we can see the difference in bacterial count, the number of debridements, the pain score, and the length of stay had all improved. So I don't know about you guys, but I know my quality, my value analysis are all looking for metrics just like this when I'm looking at what products we keep, what products we standardize to, and what products we even get to implement because of those things. I want to highlight this as well because this is my value proposition piece that I really is new piece of literature. So this shows that the effective timing of installation therapy on outcomes and costs of patients receiving negative pressure. So it was a retrospective analysis of patients with installation and dwell therapy in 2019, and it analyzed 514 of those patients, two groups. Some had it within 1 day of negative pressure application, and some had installation and dwell within 2 to 7 days. So they compared those as two separate groups. It did not compare negative pressure against installation, just early adopters versus late adopters. And so what they found was that there was a reduced length of stay, a reduced length of therapy, and a decreased overall cost of care. And this just came out in Wounds in 2022, and this is by Collinsworth. If you have not read this study, it is very impactful, particularly if you're going back to your value analysis team. So installation and dwell will provide that topical solution of your choice. Of course, everybody's going to have their own standardizations, and you're also going to have your list of approved solutions. You're going to remove that infectious material and wound debris, have a controlled, protected environment. We talk a lot about wound cleansing. I know I've felt like I've been talking about that on this whole conference already, but this is providing a way to do cyclical wound cleansing without any clinician doing it. How many of you in here have short staffing issues where you're at? Yeah, I feel like everybody does. I mean, even wait staff has short staffing issues, right? So if you're ordering a dressing change for BID, do you think it's getting done? No. At least the robot or the machine can help you do some wound cleansing for that, because we certainly know the nursing staff often is not providing that for you. And one of my other favorite things is the protection from external sources. So I heard Dr. Abby Sheffin say, I'm in a butt crack at least 3 times a day. And I think it's funny, you know, obviously sometimes we're protecting the wound from the patient or the external environment. You know, how many times have you seen a patient and say, so what kind of cats do you have? All right, so here's the history of negative pressure. You've got in 1994, obviously a much different looking machine. The Alta came out in 2011. Installation and dwell started with 2 types of dressing, cleanse and traditional. 2015, we got a reticulated open cell foam dressing that was meant to help facilitate the removal of non-viable tissue. In 2018, we got additional sizes to that in that we got the large kits and duo track pads. And then in 2021, we got both a smarter pump in that there was a technology upgrade. And we also got the complete kit, which includes the silicone hybrid drape with a fused dressing that allows through holes for the removal of non-viable tissue. And so this is this one-piece foam application with that silicone hybrid drape. I know my colleagues here will be going into more detail about that. The blue is for identification. It does not have any methylene blue in it. That was a fun question we got yesterday as well. So I'm going to highlight one of my cases, and then I'll hand it over to my colleagues. So I live outside of Philadelphia. We are not far from the largest open air drug market in the United States in Kensington. We see a lot of IV drug users. This is a gentleman that came into one of our smaller community hospitals and said that, you know, spider bite, whatever, what do they say? You know, all kinds of them, right? So ultimately, not really a past medical history other than hypothyroid, had a lot of blistering, necrotic tissue, had a CAT scan, was found to have have a necrotizing fasciitis that extended up his arm. So he was transferred to our trauma center for treatment with our plastics team with a hand specialty. He underwent an initial debridement as well as treatment with systemic therapy with IV antibiotics. So how many of you are seeing xylazine injuries in your facilities? Okay, so there's a newer drug that's cut in IV narcotics like fentanyl and heroin called xylazine. Its nickname is Tranq. It's a horse tranquilizer, so it doesn't respond to Narcan like the others, but it also causes vascular occlusions, which lead to necrosis of wounds. So in addition to seeing these necrotizing infections and necrotizing fasciitis, we're also seeing a variety of infections with the xylazine injuries as well. So this is him, day of admission to status post-debridement. You can see there's some exposed tendon and muscle. He's got some cautery marks because that's just like how my surgeons like to do it. So we were asked to come to the bedside to apply installation and dwell therapy for ongoing wound management and to assist with the buildup of some granulation tissue. So his wound was quite large and it had a little bit of necrotic tissue on it, but what I knew was that I needed to aid in the formation of granulation tissue formation. So we applied the dressing with the Holy side up, meaning that blue fused dressing. We didn't want to debride too much because we're down to fascia and tendon here, so we placed the flat side down. That fused dressing, when you place the Holy side down, removes non-viable tissue. The flat side down just helps build granulation tissue. You can see this is day of therapy 3. He had that in place. We did use barrier rings on the peri wound. You can see it's robust granulation tissue, but still having some exposed structures. By day of admission 7, we placed a xenograft over his muscle. So we used a mesh piece over his muscle. We used a fenestrated piece that was a little bit thicker over the dorsal of the hand to cover those tendons. And then we applied traditional negative pressure wound therapy. I do a mitten technique where I put foam in between the fingers and then I put drape all the way around so that they can do this but not this. Helps maintain a better seal in hard to address areas. And we left this bolster in place for 1 week. This is 1 week. You can see again robust granulation tissue and that fenestrated piece over the dorsum of the hand is still incorporating. We ended up going another week and then skin grafting him, and ultimately this is his skin graft take after 1 week and then 2 months post skin graft. You can see he's got scratch marks. So, but he's remained out of our hospital system since that time. So a pretty successful use of that evolution of the technology with stepping up to installation when needed and stepping down to negative pressure when needed. I'd like to hand this over to Dr. Klein.
Thank you. Great presentation, Liz. So as Dot introduced, and as Liz as well, I'm Rob Klein. I practice in Greenville, South Carolina. And what I'm going to be talking about today is the challenges associated with discharging a patient with negative pressure wound therapy to the post-acute setting. So what is a post-acute setting? We have a lot of places that we can send our patients to after they get discharged from the hospital. So for post-acute setting, things or places that I think about would be the long-term acute care hospital, a skilled nursing facility or short-term rehab hospital, and of course utilization of home health. When I think about patients that I want to send to the long-term acute care hospital, Liz kind of set the stage for me. My patients who receive instillation and dwell therapy, I want to have a bridge to continue instillation and dwell therapy when I discharge them from the acute setting, and the long-term acute care hospital, the LTAC, is a perfect place for me to send those patients where they can receive instillation and dwell therapy, because that's something we can't do in the home setting. So when I send someone to the LTAC, I want to begin to optimize that patient as well as to optimize that wound that we started while they were in the acute setting. When I think about sending people to the short-term rehab hospital or to a skilled nursing facility, those are patients that really can't go home just yet, but they need some type of skilled service. for their wound care, maybe for IV antibiotics and other specialized care, OT, PT, where they just can't go home just yet. So those are patients that I send to a SNF or to a rehab hospital. And that, again, my thought process is to maximize the patient as well as to deliver the wound care that need to take them hopefully onto closure. And then lastly, for the home health, those are patients who either don't want to go to a facility. I'm sure you folks have the same type of patients that I have that vehemently don't want to go to a long-term care facility or to a SNF. So I use home health for those types of patients and when it's indicated. And for those patients, it's really to maximize the care that they got while they were in the hospital, as well as maintain that care, bring that patient back to the independence that they had before going to the hospital, and of course take that wound on to progression and to closure. And we all have challenges when we discharge patients from the hospital, and these are just some of the common challenges that we all face and that we have to think about when we're discharging people from the acute setting to the post-acute setting. And polypharmacy certainly is a big challenge that we have to factor into when we discharge patients home. Polypharmacy to me is patients who are on 5 medications or more. And in our geriatric population, this becomes a significant problem. You got to worry about adverse drug events, drug-to-drug interactions, frailty, falls. So polypharmacy is a significant problem and a challenge that we have when we discharge patients from the hospital. Patients require equipment when they get discharged from the hospital, so factoring in the equipment that they have to have and the dressings that they're going to be using on their wounds when they get discharged from the hospital, and perhaps that factors in where we want to send those patients in the post-acute setting. Also, the comorbidities. You know, the patient was admitted to the hospital for a reason. They were sick. They have a wound. They have comorbid problems, diabetes. They might be on immunosuppressive therapy. They may not be ready to go just home yet, and that's where a skilled facility or a rehab hospital really comes into play, to have somebody who can manage their comorbidities when they get discharged from the acute setting. Same goes into consideration for those patients who have poor physical function and malnutrition. That's where a skilled nursing facility or rehab hospital might also come into play. And then lastly, one of the biggest challenges that I see when I discharge patients from the hospital is when they get discharged on a Saturday or a Friday evening or over a holiday, is setting patients up to get the adequate care that they need, especially when we discharge them home. Is there a home health nurse that's going to be able to do that first wound vac dressing change for them? And, you know, just by show of hands, who has problems getting patients into home health now? It's a significant problem. So you can imagine on a Friday evening or a Saturday morning when you're discharging that patient home and they got their first wound vac change on Monday, home health may not even receive the orders just yet. So a huge challenge that your patients face is when we discharge them from the acute to the post-acute setting. So we have to overcome the challenges. And this is a slide that I borrowed from Kathy Milne. We were lecturing in Charlotte together. I like that slide so much that I kind of co-opted it from Kathy for this presentation, but it really summarizes what we need to do some of the challenges that we have to overcome with respect to discharging to the post-acute setting. And it really comes down to a team approach. You know, it's silly to say that it all takes a village, but it really does take a village to take care of these patients. And we have to utilize the resources that we have to take care of them. So for our patients who have polypharmacy, 5 medications or greater, you know, going over the med list with the pharmacist beforehand to make sure that there are no adverse drug reactions potential for those patients or drug-to-drug interactions. Incorporating the use of the dietitian to take care of people who are protein calorie malnourished. For people who are frail, poor physical function, or need equipment, utilizing occupational therapy, physical therapy, certified nursing assistants to address those needs. And then lastly, incorporating the primary care provider as well as the other specialists that saw that patient while in the hospital to make sure that they're addressing their other comorbid medical problems. So once again, that team approach to take care of the patient. When we think about discharging the patient from the acute setting to the post-acute setting, it really is important that you come up with a comprehensive discharge plan. And part of that comprehensive discharge plan is really assessing the patient's post-hospital needs. You know, what do they need when they get discharged from the hospital? And I think when you're thinking about your discharge plan, the patient is an integral part of that team. So you want to include the patient and their family or their caregivers in their discharge plan. And you're going to hear me say this a couple times about medications, but you really want to reconcile those medications at discharge. There's a lot of people that are involved in these patients' care, residents, interns, attendings, maybe someone who saw the patient just before discharge that might write for a prescription. So I think it's really important that you reconcile the medications for these patients So they know what they're taking, what time they're taking them, the dose that they're taking, and again, to make sure that they don't have any adverse drug reactions or drug-to-drug interactions. You really want to create a plan that's specific for that patient. There's not a one-size-fits-all discharge plan, so you want to have a really patient-specific care plan. And then lastly, you want to give the information to the patient and the family. So I find that a discharge summary is really important, something that's in written form so that they can look at it and reference it back. I know when I go to the doctor's office, my wife will, when she gets home, she'll say, what did the doctor tell you? And the doctor may have told me 10 things that I maybe remember 1 or 2 things that the doctor told me. So having them have something that they have in hand that they can reference back to, I think is really important. So a good discharge plan that they can look back to. Again, not at the risk of repeating myself, but again, providing that updated medication list. Again, someone might have seen that patient just prior to discharge, so making sure they have an updated medication list, which they can give to the next caregiver as well, is really helpful. And then prior to discharge, making sure they have all their follow-up appointments. They saw multiple specialists while they're in the hospital. Somebody's going to be managing that wound at time of discharge. So making sure all those appointments have been scheduled before they leave the acute setting and get to the post-acute setting is very important. And then, of course, initiating those clinical and social services before they're discharged, because, again, you all have experienced problems getting home health and maybe social workers or PT out to their home at the time of discharge. Getting those things set up while they're still in the hospital is very important. And that's where, again, that teamwork, working with your case managers and your other team is very important. Now, when we have negative pressure wound therapy, there's other challenges that the patient has that we have to consider when we come up with that comprehensive discharge plan. And one of the things is, where's that patient going? Are they going to an LTAC? Are they going to a SNF? Are they going home? So who's going to be taking care of that wound vac once their discharge is a consideration that you have to consider, as well as the product and resources if they're going home. We have to get them their drape. We have to get them their foam. We have to get them their wound vac. So coming up with a discharge plan to make sure they get the product and resources that they need is very, very important. You also need to, again, address the patient factors might affect wound healing. And then equally as important is follow-up care. Who's going to be taking care of that vac? Who's going to be following that wound upon discharge? I think an important part when we discharge patients with negative pressure wound therapy is educating the patient about their wound vac. Why are we using the wound vac in the first place to get that wound to heal? So I just sit down with the patient and say that the wound vac really is set up to create an environment that helps promote wound healing. I explain to him that the wound has a tendency to produce exudator fluid, so we want to manage that exudator fluid. So we put some foam in the wound, and we have a device that sucks on the wound and draws that exudate off of it. I tell them that we want to remove cellular debris and infectious material. That helps promote wound healing. Also tell them that we want to try and protect the skin. Liz had talked about protection from external environment. That's really important. So I tell them we're going to put some type of drape over the wound that's going to protect their skin as well as protect the wound. I also tell them that it's going to reduce the number of dressing changes. If they were receiving a lot of dressing changes in the hospital, patients are excited when all of a sudden when they were getting once or twice a day dressing changes to now it's going to be maybe 2-3 times per week. And then lastly, as Liz had mentioned, edema is the enemy to wound healing, so I tell them that the negative pressure wound therapy does help reduce edema around the peri wound, which does help promote wound healing. Now, patients are going to have concerns about being discharged with a wound vac, and we need to allay the concerns that they have when they're discharged with a wound vac. While they were in the hospital, they had a nurse or a certified nurse assistant or somebody that was helping with the alarms and the beeps and all the noises that the wound vac made, 24 hours a day. But all of a sudden, the patient's going to be at home, and they might have anxiety about the device. Who's going to take care of that vac for me? Who's going to take care of that noise or that beep or that light that comes on when I'm at home? So you need to educate them about the alarms and the noises that the wound vac might create. And then you also need to let them know, who to contact and what to do if something does malfunction. Now, negative pressure wound therapy at home is a totally different thing as well. We talked about discharging people to the LTAC and to the SNF, so you still have skilled people that are taking care of the patient at those facilities. But when you discharge the patient home, now all of a sudden they have a home health nurse who's coming out 3 times a week to do a dressing change. So we need to understand that there are some significant or different challenges that the patient will have when they're discharged home with negative pressure wound therapy. And I think one of the considerations that you need to take into mind is the patient's mobility. Can they get around in their home and take care of themselves as well as carry the device? Can they go from their bedroom to the bathroom with a walker or a cane, or a bedroom to the kitchen or so forth, and navigate while carrying that device, maybe using a walker or a cane? Also, you want to make sure that they can manage the everyday functions and basic functions of negative pressure wound therapy. Not all of our patients have great vision. They might have reduced hearing. So is the patient able to hear and see when there's a problem going on. Maybe hear a noise that comes from an alarm that comes from the wound vac, or maybe see that they've lost their seal or that their canister is full. So you got to take into consideration patient sensory deficits. And then lastly, is the home environment safe for negative pressure wound therapy? I get calls every once in a while that I have a patient who's a hoarder, and home health won't come into their home because they can't navigate through the home. I have patients that are homeless and don't have a power source. So if we dispense a wound vac to them, can't send them to the gas station to charge their vac. There's got to be a power source to take care of it. So you got to make sure that the patient's home is safe for negative pressure wound therapy. So we want to come up with strategies that empower the patient. And the best way to empower the patient, I think, is educating the patient prior to discharge. And when we educate the patient, we want to make sure that they understand the basic operations of negative pressure wound therapy, how to operate the device. We want to make sure that they keep the device on, they keep it continuously charged. They need to learn how to change canisters if needed. They need to understand the alarms and the beeps and the noises that the wound vac makes, and they need to be able to recognize when complications occur, like losing a seal, or maybe their canister is full. And then who to contact when they do have a problem. Things that we can do to help them along that journey and to empower them is to enlist the patient and caregivers throughout their wound healing journey, and really to provide them with good support resources. And I think, once again, giving them printed material that describes what the wound vac is for, what to do if an alarm goes off, who to contact, say if they have a temperature that they'd noticed, who to contact if they have a temperature, or when they need supplies. So giving them some written information on just the basic functions on how to take care of themselves and their vac is important. For those that are a little bit more tech savvy, maybe have a smartphone or have a computer, there are some apps that the patient can use to monitor progress through their wound healing journey. And of course, when they get their negative pressure wound therapy device, they get a guide that they can always reference back to. So those are some of the things that we can do to overcome some challenges at the post-acute, from the acute to the post-acute setting. And with that, I'll go into my case presentations. Mine aren't nearly as exciting as Liz. That necrotizing fasciitis case was pretty impressive. I'm a foot doctor. I take care of a lot of toes, and toes are not nearly as exciting as necrotizing fasciitis going up the arm. So you have to forgive me that the geography that I work on is just a little bit smaller than Liz's and Emily's. But this is a 73-year-old African-American man who presented to our wound care center with a diabetic foot ulceration on his fifth toe of his left foot that had been present for about 3 weeks. His symptoms on presentation were rest pain and claudication. So when he was getting up and walking, he was getting some calf pain and some foot pain. He would let his leg dangle, would get a little bit of relief, but he had rest pain, which is an ominous sign for vascular disease. His past medical history, like our usual suspects that we see, at least in my wound center, because I see a lot of diabetic foot, diabetes, neuropathy. He had end-stage renal disease on dialysis. He had heart failure, apnea, and of course, vascular disease. He had never had some vascular testing. He was a new patient to me. At my center, which Dot had mentioned she just recently was at, we are part of the Vascular Health Alliance, so we have vascular surgery at our institution. So we have 4 non-invasive vascular labs at our center, so I can get a duplex the same day that the patient comes in. So I went ahead and ordered a duplex. I got it the same day. His left FA was occluded. His toe pressure on the left was 29, and his TBI was 0.15. I don't rely on ankle brachial indexes as much because a lot of these people are calcified, so ankle brachial indexes sometimes are not reliable, but his ABI, I think, was 0.38. So this is a patient that no matter what I do until I get better blood flow down, I'm not going to heal this wound, especially with a toe pressure of 29. We all know that a toe pressure of at least 40 millimeters of mercury is needed for a wound to heal. So this is someone that needs some type of intervention. So I referred him to one of our vascular surgeons. That's the other nice thing working with vascular surgeons. I was able to schedule his angiogram that same day, got him into the IR seat within 2 or 3 days. He had he had an angiogram. It was not amenable to balloon angioplasty, but he had a good target at his posterior tibial artery, so they did some vein mapping, and he was scheduled for a femoral to a posterior tibial artery bypass graft. He had his bypass graft, and while in the hospital, we did further workup on his toe. He had osteomyelitis of his toe, so he had an open fifth ray amputation as well. And this is the patient 1 month post-op, his femoral tibial bypass, still with an open wound. He's got some cellular debris and fibrotic tissue within the wound. So this is a wound that we're going to want to use negative pressure wound therapy on. This was an interesting patient. I was doing a pilot with 3M at the time when we were trialing the silicone acrylic hybrid drape. So he had the acrylic drape while he was in the hospital, and we transitioned him over to the silicone acrylic drape. So the photo on the right is with him with the silicone acrylic drape, and it's nice that it's really peel in place. It's a really neat dressing, which Emily will talk about in the next segment of this talk. This is a patient 8 weeks post-op. His wound's improving, but unfortunately developed severe calf pain post-operatively. So this is a guy who just had lower extremity surgery. He's been sitting in his house. He's been laying around, very sedentary, not moving very much. So for me, I'm not a smart guy, but I think, DVT, he's not moving around very much. So I ordered a duplex on him. Fortunately, his duplex came back negative, no DVT. So I reach out to my vascular surgeons. His calf is just tight as could be, very, very painful, exquisitely painful. So I reach out to the vascular surgeon who did his bypass, and I said, Mark, what would you do? And he recommended getting a CT angio of his pelvis with runoff. And sure enough, the patient had a soft tissue abscess at the bypass site. So he was admitted urgently from the clinic for an IND. He grew out MRSA, and he did very well in the hospital. He was discharged with a vac. So now he's got 2 wounds. He's got a wound on his leg. He's got a wound on his foot. So we went ahead and his wound was moving along just fine. We had nice granulation tissue almost to the skin line, so we just moved the wound vac up to his leg wound, used the silicone acrylic hybrid drape that he already had, and you can see those funny little circles that kind of show the silicone acrylic hybrid drape, and we just used collagen ORC and silver to take his wound onto closure. And at 12 weeks post-operatively, he did very well. His leg wound closed up very nicely. His foot wound closed up very nicely. And fortunately, we have not seen him back at the wound care center since. Second case I want to share with you is a 48-year-old diabetic female who presented with an infected diabetic ulcer for about 3 weeks duration. She came in with a rear red hot, malodorous foot. You can see this is not her first rodeo. She's missing a couple toes already. She's got an ulceration underneath the second metatarsal head. And as I shared, she just had a really red hot swollen foot. The photo on the left doesn't do it justice. She had redness going up her ankle, red streaks going up her leg. So this is someone that needs to go into the hospital. Her history, again, just like a lot of the people that we see, diabetes on insulin, neuropathy, liver disease, reflux, depression, and she was a smoker. So she was admitted for IV antibiotics. Her MRI was ordered. She had osteomyelitis of the remaining proximal phalanx and of the second metatarsal head. Her white count was 18,000.1. And she grew out MRSA and Pseudomonas. This was during COVID lockdown, so I didn't have access to the OR during this time. I was relying on my vascular surgeons to do a lot of my procedures who had OR time. So one of my vascular surgeon colleagues took her to the OR for revision of her toe amputation, so he did an open second ray on her. She had a wound vac while in the hospital, antibiotics as well, and was discharged post-op day 3 to home with a wound vac. Now, whoever has to put their patients on wound vac holiday, I certainly do occasionally. Do any of you have to put your patients on wound vac holidays? Well, she was one that unfortunately wound up with a wound vac holiday. She saw the vascular surgeon at post-op day 19. He noticed that the wound was really macerated. It needed a little bit of a break. So he did some just wet to dry dressing changes. Maybe not what I would have done, but he did what he did. But he did the right thing. He referred to wound care center moving forward. So I saw the patient at post-op day 29. She had a wound that tunneled 2.8 centimeters. The wound vac holiday gave her the rest that she needed, so we resumed negative pressure wound therapy. And again, she was a patient who was in that pilot when I was piloting the silicone acrylic hybrid drape, so I transitioned her over that drape, and I was going to follow her back up in 10 days. In the meantime, Home Health had sent me a text message because that was the first time that they were using this silicone hybrid drape as well. And this was the Home Health Agency's impression. It was that the silicone acrylic hybrid drape was very easy to use. It cut down the dressing time by half, and it doesn't seem to irritate the skin. And what she told me as well is it gave her time to do her charting. She actually got to finish her note while in the patient's home. That's how quick the application for the silicone acrylic hybrid drape was. This is the patient 49 days post-op. We have granulation tissue almost to the skin line. I went ahead and discontinued her wound vac. I transitioned or changed her wound care over to collagen silver and ORC. Post-op day 46, wound is almost closed. And then post-op day 78, her wound is closed. She was fit for diabetic shoes and custom insoles. And knock on wood, she has not been in our wound care center since. With that, I'm going to turn it over to Emily. She's going to talk about peri-wound skin management.
Thank you, Dr. Klein. So my name's Emily. I'm going to give you a little bit of an overview of the new hybrid silicone drape. I kind of have an interesting position. I work in an inpatient setting 2 days a week, an outpatient setting 3 days a week, and then I cover an LTAC. So I see the whole gamut. I sometimes think I follow the patients or the patients follow me, one of the two. So when we talk about peri-wound skin management, our top challenges when we utilize negative pressure wound therapy, if you guys have ever utilized it before, any brand, any type, you know that it can be very hard to maintain that seal, especially if it's in a hard spot that's more sweaty, that's in a crease, that's close to another wound. It can be really hard. It can be hard to protect that peri-wound skin integrity. You can get blistering at the edges, you can get fungal infections underneath there. There might be pain with the dressing removal. A lot of our patients say they have pain. The drape can be really hard to separate. Once it sticks together, it rolls. It's hard to take apart. And that can be hard to lift and reposition. So this is examples of problems that we commonly see. So in this wound, the seal had been lost for several hours. This one we have peri-wound maceration. This one we have very bad peri-wound skin excoriation from the granufoam touching the skin. And then, like I said, it's really hard. Once that drape is stuck to itself, you have to throw it away and start over. So how do we overcome these challenges? How do we protect that peri-wound skin but still maintain moisture control and an adequate seal? And then, of course, we want to address our patient's pain. How do we decrease that with dressing changes? A lot of times our patients have, it's kind of a combination of anxiety and pain. If they had a really bad experience the first time that the dressing was changed, oftentimes I see this from patients who will have the dressings applied in the OR and the first dressing change at the bedside, they'll have a lot of pain. And then when it comes time for the next dressing change, it'll be more anxiety, that anticipated pain. So making sure that we're addressing those. So one thing that we can use, like we had talked about before and Dr. Klein had mentioned, is this silicone acrylic hybrid drape. And if you've never seen it before, I highly recommend stopping by the booth in the exhibit hall to take a look at it. It is very unique. So the benefits of this drape is it's very easy to use. It only has one layer. It's repositionable, which is very unique. So you have time. If you apply the drape, you have an area that got a crinkle in it, because we all know when anytime we apply anything adhesive, it's very hard to get it flat. You can lift it up and straighten those creases or crinkles out. It's very skin friendly. It saves time because there's a lot less cutting. And then there is protection to the peri-wound skin, and then it has a very high seal strength. So how is it different? It has these little circles. The circles inside the circles is acrylic, so that ensures that tight seal. Outside of the circles is a silicone layer, and what the silicone layer does is it allows for easy removal of the drape, so decreases the patient's pain. Unlike our original drape, which we've all seen, we had it burned in our head, you know, the 1-2 blue, the window painting to protect the peri-wound skin. There's a lot of arts and crafts involved. And then patients say that there's a lot of pain with the removal at times. Versus our silicone drape, which is a one-liner release. There is no need to window pane. This gives a lot of people anxiety. I've done a lot of talks about this in the past, about this drape, and that's kind of the biggest question we get is, well, how do you protect the peri-wound skin from the foam? How do we, if you don't window pane? Well, the nice thing about the acrylic drape, because you can lift it and you have time until it's set, what we do is you kind of want to just walk your fingers around the edge of that wound to get that really good seal right up to the edge. There's less cutting. There's the main thing that you need to remember, though, with the silicone drape is that you're cutting between the circles and not through them, because that will help adhere it down on the edges. And you also have to have at least a 5-centimeter area of draping around the peri-wound skin. So traditionally, with the traditional drape, they say about 2 to 3 centimeters. With this drape, you want more, and the reason is so that you can have more of those acrylic circles really adhere down to the skin. You don't need to use any extra skin prep, so if any of you use the cyanoacrylades or some of the other types of skin prep, you don't need to use it, and the reason why is because if you think about it, this drape is designed to lift and reapply, so when you're lifting it, you can see that the skin prep is sticking to all of those acrylic circles, and that will interfere with your adherence if you place it back down. So how do we utilize the silicone hybrid drape? You can utilize it the same way that you would with the traditional drape. You can use it in the inpatient setting, the outpatient setting, the SNF, LTAC, pretty much anywhere you use the original drape. So first things we want to do is we want to perform that thorough assessment of the peri-wound skin, making sure that we're cleaning it really well. A lot of times people forget about that peri-wound skin when they're cleansing. I know Dot does a very good talk about cleaning that peri-wound. Clean it like you mean it, the peri-wound skin, and making sure that that is all dried before you're applying anything. Of course, we do our thorough wound assessment, looking at the whole patient, what are their comorbidities, making sure we're making an appropriate diagnosis. Is this appropriate for negative pressure wound therapy? Identifying those comorbidities that could impact healing. What is the patient's healing potential? Like Dr. Klein had said, what is their vascular status if it's a wound that's on the lower leg or the foot? And then looking at patient factors, their perception, expectation, and compliance. I find it's very important to set expectations with our patients from the beginning. A lot of times they will come in and they will say, well, I've had this wound for 2 years, but I think you need to heal it in a week. So setting it from the beginning, you're going to have this negative pressure wound therapy. I always tell them in the outpatient setting, we get this approved for 3 months. It doesn't mean you're going to have it for 3 months. It doesn't mean you're going to need it for 3 months. We just do it 3 months at a time because that's just how it works in our area. And then making sure we're setting up compliance and making sure we're checking on them, especially in the home setting. There is ways to check if you've ever used the Freedoms in the ActiveX. There are history that you can go under, and it tells you if the patient has turned the machine off or turned the machine on. I've had a few patients that they'll say, I just turned it off to shower. It's only been off for like half an hour, and you look back and it's been off for like 10 hours. And then making sure you're doing that complete wound assessment, making sure there's no tunneled or pocketing areas, looking at the exudate, is there any bioburden that you need to take care of? When we talk about peri-wound skin, what is peri-wound skin? The definition of peri-wound skin is that skin that's up to 4 centimeters around the wound edge. This can extend beyond if the skin is damaged. A lot of us have seen those patients, especially with venous leg ulcers, where the ulcer itself will be up higher in the gaiter area, and you'll see maceration or excoriation distally to the wound because of where the drainage has run. We want to look at the health of the peri-wound skin. Where is the epithelial migration? Is there any desiccation or maceration which can lead to that delayed healing? So our peri-wound skin assessment, a couple of things that we want to note is making sure that we are assessing the temperature. Is the wound really hot? Is there any signs of infection? Or is it really cold or pale, which can indicate the blood flow isn't as good? The location, is it over a bony prominence, this wound? Are there any areas that are exposed to high friction and shearing? And when I say areas high friction and shearing, this doesn't necessarily mean over bony prominences. Do they have a brace that they wear that might be rubbing, or is there something that's rubbing in that area? Do they have pants that are too tight and that pant line is rubbing on it? Do they have skin folds that are folded over that are rubbing? And then we want to look where the peri-wound skin breakdown is occurring. Is it distally to that wound? Is that drainage running down because of gravity? Then we want to look at the shape of it. Is there any irregular borders? Is it a large area of maceration? Is there undermining or tunneling that can indicate shearing? We want to look at in this picture, you can see there's irregular borders on the distal end that are characteristic of shearing. So when the patient was pulled up in the bed or sliding down in the bed, that is creating that jagged wound edge. We want to look at color. Is there redness? Is it blanchable, non-blanchable? Is there deep tissue injury if this is a pressure injury? Is there dusky ischemic changes? And then if it is a venous ulcer, is there hyperpigmentation or chronic venous changes such as stasis dermatitis? And then the maceration, where it's that white, looks like it's been soaking in a bathtub for too long. We want to look at the quality of the peri-wound skin. Is it transparent, thin, friable? Is it prone to tearing easily or blistering easily? Do they have a lot of edema? Is it too wet? Are there any scars or deformities? We want to look at if there's rashes or varicosities present. Then the exudate, we want to assess the amount. Is it really thick? Is it really thin? Is it bloody? And then the color and consistency as well. So when we talk about applying the hybrid silicone drape, like I said, we want to have that 5 to 7 centimeters around the peri-wound skin. We remove the one release liner. There are 2 handles on each end, so you are going to put them down. The biggest thing with this drape that is like the traditional drape also, you don't want to pull or stretch the drape, so there's not a lot of high tension. If you place a drape with high tension is when you'll get the blistering at the edges around that drape. Also, if you're anticipating a lot of edema, making sure you're controlling that edema to prevent that blistering. We want to smooth out any creases, which will help prevent the leaks. And then once the silicone hybrid drape has been placed, you want to push around the wound, like I said, to help protect that skin right up to the edges. So a couple of things when we use the silicone hybrid drape, it can be applied with ease. When we talk about it applying with ease, it's very easy to conform. So you don't really need to use a lot of seals or paste or things like that like you have in the past to kind of fill in those crevices. This drape actually molds to them quite well. It has a pretty high tack for about 48 to 72 hours. It saves time and reduces waste. When I talk about applying it with ease, this is an example of a patient. He's a 56-year-old male. He has a history of type 2 diabetes. He has an incomplete spinal cord injury secondary to a motor vehicle accident. He's wheelchair bound. He is one of our patients who has had multiple pressure injuries, multiple failed skin flaps. So you can see that the landscape is pretty rough. He's got a lot of creases, he's got a lot of bumps, the anatomy isn't where it's supposed to be, so they're very hard to get a seal. So we noticed with him, he was actually utilizing the traditional drape, but he was presenting with a lot of skin excoriation around there because we just weren't able to get a good seal. So we switched him to the hybrid drape, and after day 3, you can see that there's improvement in the peri-wound skin, and day 6, it continued to improve. So the other nice thing about this drape is it's easy to remove. There's a lot less pain reported with it. So it supports the healing process, does those things like Liz and Dr. Klein were talking about blocking out external contaminants. It has, though, that acrylic strong bond, but that silicone layer is gentle to remove. So this is an example of a patient that we utilized it for ease. To decrease pain. She was a 37-year-old female. She had an infected left port, previously been radiated to the left chest area. This port was removed because she had had an infection. She had a history of breast cancer. So you can see with her, we started with the traditional drape. Upon removal on the skin, her skin was very fragile. She had a lot of pain because of the previously radiated. So this is what it looked like when the traditional drape was removed. So we switched her over to the hybrid. And you can see this is day 3 when the dressing was changed, that the peri-wound skin was improved. She had reported significantly less pain with the removal of the dressing as well. The next option, or the reason we would choose this, is called seal in the heel. It protects that external. An interesting thing with this patient was she was a 67-year-old female who had a total hip arthroplasty that developed a seroma. That seroma was evacuated. She had retention sutures placed, so that's where you can see that railroad tracking on above and below the wound. So normally with these types of patients, we would use a secondary type of dressing in those areas underneath of the drape, either a hydrofiber or a foam of some sort to help with that. Because we were trialing the drape, we decided just to place the drape directly over this. And you can see by day 14 that those railroad trackings are almost completely gone utilizing this drape. So in conclusion, this new hybrid silicone drape, it conforms to the different anatomical locations easily, provides a tight seal for that 48 to 72 hours, and there's low tack, so you can remove it and place it back down for up to 20 minutes after originally placing it. And it's very skin friendly with dressing removals. We have had a lot of success. A lot of patients say that they have a lot less pain, especially if they've utilized the regular drape and then switched to the hybrid drape. The only thing that I will say about the hybrid drape, if you haven't ever utilized it, there is a little bit of a learning curve just because you have to remember to cut the bigger area, walk it up to the wound edge, and then make sure that the skin, because it is silicone, is very dry before you're placing that down. Otherwise, it'll have a hard time sealing. So now we'll go to questions, or are we going to? Maybe?
Yeah, so while you're still up there, there was a question, and you can ask, we have a microphone that Jessica has, or you can ask it in your app if you've downloaded it. There is a question about the kind of drape that you might put under the bridge if you're, and I think it related to the hybrid drape. Do you use the hybrid drape under the bridge, or do you?
You can use, yep, we do use the hybrid drape underneath the bridge. Right now, the only slight problem with that is that there's only one sheet that comes with the medium. So if you have a larger wound that you're needing to bridge a long ways away, we have you either get another sheet, because they do come individually, or I have in the past used the traditional drape over the top of the bridge, so it's not touching the patient's skin, it's touching the actual dermatac, it's touching the patient's
You
skin.
can sort of mix and match them. if you
Yeah,
want to, I think is it, yeah.
Just because we have, like everybody I'm sure has a surplus of leftover pieces of drapes that patients bring in.
The thing that I do with, is similar to Emily, but in the outpatient setting, when the patient's home, I'll have them order the large Dermatac, because that comes with 2 pieces of drape. So we bridge with the Dermatac. There's a little bit of a learning curve to it, but if you order the large Dermatac, or large silicone acrylic hybrid drape, you will get 2 pieces of drape for that patient.
Okay, Liz, I'll send this one to you. So I think the question is asking who can apply and use the installation? It says who has the credentials?
Yeah, who has credentials for installation was the question. And I think, really any wound care clinician. So ultimately, it's about the training, right? So in my institution, we do not allow our PCAs to apply negative pressure, whether it's installation or traditional. However, we do have LPNs, and they are able to apply that. So I think it's a little bit more of like an institution-based thing, and just checking with like your nursing practice acts. And yes, physicians can apply it as well, although they don't always. If you raise your hand high, Jess will come over to you, just so we want to make sure we get it in the microphone.
Yeah, I've got a couple more here.
Okay.
So do any of you use intermittent settings for
So
negative pressure?
DPC, I do not
Okay, yeah, you
currently
wouldn't do it that.
use, but there was some initial studies that showed that you may have an improvement in granulation tissue formation through intermittent use. And I think since that point, I've used installation therapy, which is inherently intermittent, but also has proven to be better than just DPC therapy, which is dynamic pressure control therapy as well.
I tried to use intermittent in the home in an outpatient setting, and I'm going to rethink it because a lot of people do see better granulation tissue, but we'll do intermittent during the day and maybe give them a break from intermittent at night, because it does turn on and off, and people find it disturbing to their sleep. So you can program it or help them understand how to program it to turn the intermittent off at night. Rob, do you use intermittent? Do you use intermittent settings?
Similar to what you do, yeah.
Yeah, how about you? Do you use them? Okay. And then I'll answer this one. Why is it hard to get silicone drape in the outpatient setting? Well, it's getting easier. And one of our challenges is, first of all, we only were able to get the hybrid drape like last fall. But also, if a negative pressure has been started in the hospital, they tend to historically order the regular, like Simplace or the ones with just the regular drape, and then we have to ask for these hybrids separately. And then if you call the service center, they'll say, well, you already got the drape. So it's just really a matter of it has to be ordered separately. But if you're the one starting negative pressure in the outpatient setting, go ahead and order the hybrid drape with it, and then the patient will have it. Let's see. Can you?
Cost to the hybrid dressing, or is it the same?
What's that?
Cost-wise, is it the same?
You know, I think the hybrid drape might be a little higher, but we haven't had any trouble getting it. If negative pressure is covered, then it has been covered. So we haven't had any issues with insurance coverage not covering that one. Can you use the silicone hybrid drape with areas that might not have a 5-centimeter peri-wound available near the anus, knuckles, or toes?
Yes. Yeah, you can. It's a recommendation. It's not a hard and fast. I've had a lot of perianal lesions, not personally, but professionally. And we've achieved a good seal with Dermatac. We actually find that in areas of high moisture, that it achieves a better seal than the acrylic drape.
And I think it depends on the patient activity. If you've got someone lying in an acute care bed, that might be a little easier. I found one of the first ones I did not, I was so proud of what it looked like after I got it on, and it didn't last 2 hours. But it was a girl who was transferring. She was paraplegic. She was transferring, so it was a learning curve. And I want to emphasize, Emily, what you said, when you're cutting the drape, to cut it in the flat part, don't cut through the little bubbles, and you'll get a better seal at the edge, if that makes visual sense. So, all right, that's the questions that we have on here. Any other questions from the audience?
So the credentials part, that was my question.
Okay.
In order to elaborate on that, just wanted to know if you have to go through a formal training to do this, or who is allowed to, who is allowed to write orders for that and so forth?
I think anyone, I think anytime you're doing anything new with negative pressure, or even if you're going to go from, say, the powered system to a mechanically powered, is to utilize the clinicians that the companies have in order to come in and do training. So yes, you as a physician certainly can order it, but the people who have to support it, they need to be trained. So I think utilizing the company's clinicians is really the best way to go. So it is 1:30, so we're going to have to go ahead and break so we can get to the next sessions. I appreciate my panel here, and I appreciate you guys joining us.